It's a pleasure to be with you. The title of this talk is Practical Epidemiology, Introduction. There are no disclosures for this presentation. Objectives include briefly review the history of epidemiology, define epidemiology, discuss why epidemiology is important for public health practice, and describe uses in current public health practice. Much of the content of this talk comes from the text Epidemiology 101, Essential Public Health Series by Robert Friss. Several other supplemental sources will also be used. Let's first review a brief history of the field of epidemiology. Hippocrates, who lived from 460 to 370 BCE, emphasized reasoning versus superstition, setting the basis for the scientific method. Paracelsus, 1493 to 1541 CE, initiated the field of toxicology by studying the dose-response relationship of medications. John Graunt, 1620 to 1674 CE, was the first to employ quantitative methods to vital statistics. Ramazzini, 1633 to 1714 CE, founded the discipline of occupational medicine and was a pioneer in the field of ergonomics. Sir Percival Pott, 1714 to 1788 CE, described an environmental cause of cancer, scrotal cancer in chimney sweeps. Edward Jenner, 1749 to 1823 CE, developed a vaccine for smallpox using the cowpox or vaccinia virus that he administered first to a dairymaid, Sarah Nelms. John Snow, 1800 to 1899 CE, was an anesthesiologist by training. He studied the cholera epidemic in London and identified the cause, contaminated water, associated with the Broad Street pump circled on the map. Each mark on the map is the physical location of a case of cholera and helped Snow deduce that the pump was essentially the geographic center of the epidemic and could likely be the culprit. His method was what is termed in epidemiology a natural experiment that is still commonly used today. A natural experiment is defined as a naturally occurring circumstance in which subsets of a population have different levels of exposure to a supposed causal factor in a situation resembling an actual experiment, where human subjects would be randomly allocated to groups. This slide lists the major contributions John Snow made to the field of epidemiology, including the powers of observation and written expression, description of epidemiologic methods, including mapping and data tables to describe the outbreak, the use of the natural experiment epidemiologic method, developing recommendations based on the data, using that data to develop a practical solution to the problem. In this case, remove the pump handle, which Snow did. This picture is the famous Broad Street pump with the handle removed. Let's continue with a few more key historical considerations. William Farr, 1807 to 1883 CE, developed a more sophisticated system for codifying medical conditions. Robert Koch, 1843 to 1910 CE, developed the famous Koch's postulates, an extremely important tool that helps determine infectious disease etiology. The postulates include: the organism must be observed in every case of the disease. The organism must be isolated and grown in pure culture. The pure culture must, when inoculated into a susceptible animal, reproduce the disease, and the organism must be observed in and recovered from the experimental animal. There were several situations in the 20th century that groomed the field of epidemiology and its uses, including the Spanish flu epidemic of 1918 to 1919, the Framingham study of 1948, intensively studying coronary heart disease, development of the Centers for Disease Control and Prevention Epidemiologic Intelligence Service, EIS, in 1949, the Surgeon General's report in 1964 linking tobacco to significant health risks, including cancer, and the successful smallpox eradication program that culminated in the last smallpox case seen in 1977 in Somalia. Let's now consider some key definitions. An epidemic is defined as the occurrence of a health-related event in excess of that expected. Examples would include infections like influenza, Ebola, Zika, measles, meningococcus, pertussis, hepatitis C, etc. Epidemics may also apply to non-infectious diseases like diabetes, suicide, heart disease, asthma, mesothelioma. The term epidemic also applies to risk factors like obesity, hypertension, inadequate exercise, e-cigarette use, and exposures like those to asbestos and erionite associated with mesothelioma. Once again, the term epidemic is defined as the occurrence of a health-related event, not just a disease, in excess of that expected. The term pandemic means a worldwide epidemic. The Spanish flu pandemic 1918 to 1919 killed 50 to 100 million people worldwide and infected 1.5 billion, one-third of the world's population. The 2009-2010 H1N1 influenza season was another example of a pandemic. Worldwide, the H1N1 pandemic in 2009 to 2010 caused an estimated 201,200 respiratory deaths and an additional 83,300 cardiovascular deaths associated with H1N1 infections. 80% of these deaths were seen in people under 65 years old. 51% of H1N1 deaths during the pandemic occurred in Asia and Africa. In the United States, H1N1 caused 60.8 million cases from April 2009 to April 2010, resulting in 274,304 hospitalizations and 12,469 deaths. Similar to worldwide data, 87% of the deaths were in those under 65 years old. Children had a 4 to 7-fold and working adults an 8 to 12-fold higher attack rate during the H1N1 pandemic versus a normal influenza season. Those over 65 had 75% less deaths and 81% less hospitalizations versus a normal flu season. So H1N1 targeted children and working adults. Everyone expected a high mortality rate in the elderly. That didn't happen. As the epidemiologic data accumulated, it became clear that the previous pandemic planning was flawed and required a change. Public health and healthcare needed to focus more on working adults and children to decrease mortality and hospitalizations. The main tool to do this was early treatment of symptomatic patients, since an effective vaccine was not available. Why the elderly had less risk with H1N1 is still somewhat speculative, but may have been at least partly due to cross-reacting immunity from previous infections. This H1N1 pandemic example is a good illustration of the use of epidemiologic data to influence public health strategies to protect the public. The word epidemiology comes from Greek roots. Epi means upon, demos means people, ology means study of. So epidemiology means the study of something that happens to people or populations. This definition gives more detail. Epidemiology is the science concerned with the study of the factors determining and influencing the frequency and distribution of disease, injury, and other health-related events and their causes in a defined human population for the purpose of establishing programs to prevent and control their development and spread, also including the sum of knowledge gained in such a study. Epidemiologic study can be divided into two stages, including descriptive epidemiology and analytic epidemiology. Descriptive epidemiology is often the focus of state and local health departments and often represents the first part or stage of an epidemiologic study. Descriptive epidemiologic data includes time, place, and characteristics of those affected. Descriptive epidemiology data leads to tentative theories regarding cause and effect, or even just an association. The result of descriptive epidemiology is the generation of hypotheses. Analytic epidemiology is usually the focus of academic institutions, the second stage of epidemiologic study where hypotheses are tested. Looking back at our definition, let's focus on the words human population. These words are key for public health epidemiologic work. Tools to analyze data are used in many disciplines, including clinical medicine and public health, though each has a different focus. Public health epidemiology generally targets aggregate data of groups of people or populations, where clinical data focuses more on individuals. The Institute of Medicine in 2012 strongly recommended that there be greater integration of public health and clinical medicine for the health and wellness of our society. This would include better integration of population-based epidemiologic data with clinical data to inform collaborative programs to ultimately improve the wellness and health outcomes of people in this state and nation. We need more collaboration and partnerships, including data sharing between public health and clinical medicine in the future. Let's briefly consider some additional detail from the 2012 Institute of Medicine Integration Report. In the report, the expert committee identified a continuum of integration from isolation to merger. Isolation is where parties operate in silos and are not aware of the work of others. Mutual awareness means the parties are aware of other programs but are not working together. From cooperation or coordination to collaboration and partnership, there is progressively an increase of joint activities and interdependence. Merger is where parties actually diffuse into one group with no separate distinction. Most public health and clinical experts agree that we currently operate in the area of mutual awareness and cooperation with little true collaboration or partnerships. The Expert Committee on Integration from the Institute of Medicine recommended more collaboration and partnerships, the breaking down of silos, to better influence health and wellness outcomes in the United States. Appropriate data integration is needed to drive integration strategies for both public health and clinical medicine, and is particularly important in times of austere budgets and sustainability concerns. People, communities, and organizations will only be interested in and put their resources into things they feel are important, their perceived needs. Integration work will only be effective when focusing on issues deemed important to all integrating parties. Regarding data integration, as depicted in this diagram, it's the area of data overlap that's ripe for integration and key for sustainability of the integration partnerships. This is the data area that public health and clinical medicine will jointly invest in to meet their needs. This is the data area of interest and supported by grants from the CDC, the major funding source for public health, and other organizations like the Robert Wood Johnson Foundation. Public health can use data from this area to develop strategies to improve its mission in primary prevention, reducing risk factors for the population as a whole. Public health can only use CDC dollars for approved grant activities. Utilizing data in the area of overlap could enhance reimbursement for clinical medicine in the future. Clinical medicine needs new sustainable business models to move from a fee-for-service disease orientation to a wellness outcome reimbursement model in the near future. For this reason, clinical medicine will support this area of integration with resources. It will help their bottom line. Integration seeks to find these areas of overlap, the sweet spots, where all parties will benefit from integrative collaboration and partnerships. Let's now focus on the word distribution from our definition. Distribution in the definition implies that there can be variations in the occurrence of health issues in different populations. Communities are comprised of individuals across the age spectrum, subgroups of the larger population. For example, this chart shows the leading causes of death in North Dakota by age. Unintentional injury accounts for the greatest number of deaths to people between the ages of 1 and 44. Suicide is the number 2 cause of death between the ages of 15 and 34. Heart disease and cancer rise to common killers in middle life, being number 1 and 2 at 45 years and older. This type of epidemiologic demographic data translates into different public health strategies based on age. Distribution epidemiology is important. Next, let's consider the term factors or determinants that influence the frequency and distribution of health issues. Factors or determinants mean any input or exposure that changes the condition of health or other defined health characteristic. This could include biologic agents like bacteria, parasites, viruses, prions, chemicals like toxic pesticides, carcinogens, and lifestyle factors like exercise, stress, diet. The impact of exposures include things like concentration of an agent, time of exposure to an input, like the amount of sun exposure associated with skin cancer, or number of bacteria that are associated with disease onset. For example, Salmonella generally requires exposure to many organisms to cause disease, where Shigella requires very few. Let's consider factors or determinants a bit more. This graph presents the 6 most common causes of death in North Dakota, including cancer, heart disease, Alzheimer's disease, chronic obstructive pulmonary disease, stroke, and injury. Obviously, the most common causes of death for the whole population in North Dakota are cancer and heart disease. Now that's very helpful data, but not the whole picture. What are the underlying risk factors or determinants of health, the true etiologies of these leading causes of death? Let's look at some national demographic data regarding health determinants. Premature death is considered death before 75 years old. Of factors contributing to premature death, genetics contribute to 30% of those deaths. Currently, it's difficult to alter that determinant. 40% of premature deaths were due to behavior or lifestyle issues, personal choices. 10% were caused by healthcare system deficiencies. So if the entire population had timely, error-free treatment, the number of early deaths would be reduced by only 10%. From this data, it seems that a strategic focus on poor behavior and lifestyle choices makes sense. This is an example of how national determinant data can inform and influence public health strategies. That's helpful. Let's now look at factor or determinant state-level data. This graph lists the risk factors, determinants, or underlying causes of disease and death in North Dakota. Tobacco is the #1 factor causing cancers, pulmonary, and cardiovascular disease. Poor diets and lack of physical activity are in second place, significant as a cause of diabetes, heart disease, stroke, and some cancers. This is an example of determinant data that should be used to help develop public health and healthcare integrated strategies at the state level to improve the health and wellness outcomes of our citizens. Our epidemiology definition includes the following phrase: control their, the factors, determinants, and underlying causes, development and spread, outcomes. The outcomes means the diseases and their complications caused by the factors or determinants. So in practical epidemiology, we need to gather and analyze outcome data. Epidemiology is generally about objective numbers, measurable quantities, counting the number of things or events. An epidemiologist can count outcome data in almost all instances. The two most common outcome measures are morbidity and mortality. Morbidity is the number of illness-related measures associated with a disease or health issue. Mortality is the number of deaths due to certain risk factors and diseases. For example, this is North Dakota epidemiology influenza surveillance data from the 2016-2017 season, reported on May 25, 2017. The most common organisms that were fully typed were influenza A H3N2 and B Yamagata. There were 7,484 total cases. Common age groups with symptoms were less than 10, 10 to 19, and 60 plus. Morbidity data, 252 were hospitalized. Mortality data, 25 deaths. Public health, local and state, along with numerous healthcare professionals and systems, gather this type of surveillance data, not only for infections, but also non-infectious diseases. Good epidemiologic data is needed by public health and healthcare systems to develop adequate strategies and programs. The first word in the highlighted phrase is control. Control there, the determinants and factors, development and spread, the outcomes. Epidemiologic outcome data informs all aspects of public health and healthcare programs and strategies, including evaluation strategies, formative process outcome, program designs, health promotion, disease control, environmental regulation, healthcare facility regulation, emergency preparedness and response, community engagement, needs assessment processes, national, state, and local or community, and health policy. There are three types of prevention, including primary prevention, preventing the risk factors, determinants, the underlying causes of disease and death. This is the mission of public health. Public health is the only health profession that has as its primary mission primary prevention. Clinical care focuses on secondary prevention or curative care, and tertiary prevention or rehabilitation and palliative care to mitigate complications and death from disease processes. Both public health and clinical care deal with all three types of prevention, but with a different priority. Once again, the areas of overlap, the areas where clinical care and public health work on similar issues, is a prime area for collaboration, partnership, and integration. We need to do more of that for the wellness and health of all of us. In summary, epidemiology is the study of the health factors and their causes in population groups. Hippocrates introduced the scientific method, the base for the discipline of epidemiology. John Snow is considered the father of modern epidemiology through his study of cholera in London in the 19th century. Epidemiologic study can be divided into two stages: descriptive epidemiology and analytic epidemiology. Public health and clinical care can integrate in areas where perceived needs around data and implementation intersect.
Take your public health practice skills to the next level. Our specialized certificate courses give you an opportunity to work systematically through a public health topic and demonstrate your understanding of that material in a capstone project. Learn more and sign up at ndphtn.com/certificates.